I want to first apologize for not being with you as much as I would like to be, but something prevented me from being. But I'm very happy to. Very important workshop on PD. I want to thank Dr. Abdul Latif for organizing this, and I'm very happy to see it being chaired by my dear friends and colleagues, Dr. Naja, Dr. Shahad, and leaders in PD. And I'm being tasked here to talk about the physiologic basis of PD. And when we designed this session, I put myself in a high-level, global, forward-looking talk by Dr. Kapka and take you back to almost 1,000 feet to go over the basics of peritoneal dialysis. But it is really important that we go over the basic physiologic principles that will guide how we prescribe and how we manage in our patients as we go forward. So for those who are very familiar with this, I apologize. For those who find it a bit interesting, I will be happy to share with you. Okay, so here we go. That's the title of my talk. These are my disclosures. This is my own views and do not represent ISBD with this chapter or ISBD in that matter. The learning objectives are simple. Review the anatomy and ultrastructure of the peritoneal membrane, present clinically relevant physiologic principles underlying peritoneal transport, including diffusion, compaction, and ultrafiltration, differentiate mechanisms underlying small solute clearance from ultrafiltration, and highlight the perspective of membrane preservation through these physiologic principles. Excuse me for just 1 second, I need to make the video a bit clearer for me to see you. Okay. Very old graphic of the peritoneal membrane. So let's orient ourselves. And I'm going to switch to pointer so we can see it better, you and I. Here we go. So, this is a peritoneal space here on the right side of the slide. These are the epithelial cell layers. Then there is some space, an interstitium. Then there is a capillary crossing line. So the exchange is going to happen between the plasma in the capillary and the peritoneal space filled with a dialysate artificial solution. So this is your organic dialyzer. So obviously, it immediately comes to mind, how does it work, what impedes it, the distance, how many capillaries there are, how thick this is, and the disease in it, and then there are the molecular level transport mechanisms that we detail in a bit. The flow is bidirectional for solutes, as well as for water. The endothelial cells happen to be where some of the barrier lies, especially through the presence of aquaporin. The endothelial cell layer is not really a barrier, but checking for, let's say, CA125 can indicate the health of the endothelial layer. This is a bit more sophisticated look at this. This is not new, it's almost 25 years old work, but it's excellent to depict what we're talking about. So I mentioned here at the bottom of the slide that peritoneal space, that's the endothelial layer, that's the interstitium, nice and lacy, and then we see the endothelial layer of the capillary blown up, and this is what are stained for aquaporins here, and you see RBCs coursing plasma, of course, suspending them. So what I depicted is real in a histologic immunohistochemistry depiction and confirms what I just mentioned. So going a little bit deeper, this is a wonderful work that was published also almost 25 years ago by the late Dr. Rippe, and Rippe really predicted the presence of different pores in the peritoneal membrane in terms of size, and that's really key for how peritoneal dialysis actually work and give us the potential to use it as a therapy that Ayman so elegantly presented in terms of outcomes and correction of urea and more than that. So here we go. So if this is a small pore between the endothelial cells, okay, it will allow small molecules to pass, urea, creatinine, glucose, and the like. Water will pass through the cells, and this is what they call transcellular pore. Now we know it's aquaporin. And then they predicted the presence of large pores, maybe not frequent in number, but those large pores will allow albumin to pass. That's why we have some albumin loss in PD, but also it may be the savior because it allows bigger molecules to pass that are uric molecules or molecules that are essential to run. So let's see how this ultimately plays out. So solid movements across the peritoneal membrane is like any other membrane. There is diffusion and convection. So diffusion obviously is movement of a solute across the semi-permeable membrane. If it allows it to pass in terms of, like, let's say, pore size or charge, what the gradient is permissive. Convection is what that solute is carrying with whatever water is moving through that pore or through that barrier. And of course, size still plays a role. You cannot get a large bubble even if you have a torrent of water if the holes are small. What are the forces at play? Concentration gradient for and foremost. So in peritoneal dialysis, urea, creatinine on the plasma side will have a favorable gradient to move into a zero concentration urea and creatinine dialysate. The molecular weight as well as the solute size in correlation will restrict how fast it moves and if it can move at all. When you order hemodialysis, you order a surface area, 1.5, 1.8 meters square. Well, you can't order a surface area, you can order a dialyzer. Well, it comes pre-determined that the entire peritoneal space, if it is covered with dialysate, is potentially a dialyzer space, but it's vascularity actually what matters. If there are a lot of capillaries, this is a highly vascular membrane, you would think that this is a more effective surface area, which is correct. And if it is less vascular, then that will be a less of a surface area. So we're differentiating between the actual physical surface area as well as the vascularity of the surface area. We might feel very happy to have a very vascular membrane, which means I got a very large surface area to work with, but that may actually be detrimental when we talk about ultrafiltration. It will be detailed out as we go. Of course, you need to bathe that peritoneal space, those capillaries with peritoneal fluid, so the larger the volume, the more you cover of that membrane, the crevices, it touches every potential capillary up to a limit. And that limit could be how much volume we can put in a patient, depending on their size and to the comfort that they can have. This has been well studied and is beyond the discussion today. Membrane resistance is intrinsic to the membrane. There could be a change over time. There could be fibrosis. A molecule may not pass as easy. And those can be determined later by functional tests that we'll mention very briefly, like the PET test. So, going back to the principles, some of it will be repetition here, so I'll be a bit quick. Diffusion of a solute occurs down this here. Concentration gradient across a permeable or semi-permeable membrane, like the peritoneal membrane. And convection is what we call solvent rank, it goes with the water flux. The larger the molecule, the slower the diffusion, we know that. And it is affected by all the factors I mentioned. You cannot really dial in the capillary blood flow either. But it does not seem to significantly affect diffusion. Quote unquote, a low blood pressure means a low capillary blood flow seems to continue to work in PD. That takes me back to my years as a fellow a long time ago, where we used PD acutely instead of CRRT when it was not available yet. And it worked, even with the blood pressure of 80. So we know that this can still be possible to do PD and convection, diffusion, and exchange. Civic. This is a more advanced concept, but it's not really difficult. It is the resistance of the membrane to a solute passing by. So this is an intrinsic property of the membrane. It occurs across the semi-permeable membrane, and we know that from the data I'll show you about sodium. And essentially, it restricts some movement versus, let's say, sodium versus the movement of water. It is really a result of the presence of the aquaporin or the ultra-small pores. The civic coefficient is a ratio between the concentration of the solute in the ultrafiltrate and its concentration in the plasma, assuming that net diffusion is zero. So not to complicate this. And so if it is a high coefficient of sealing means it moves better with the compaction. Putting it another way, the sealing is the opposite of the reflection, which means the membrane is reflecting that solute completely. That actually may be good on one side and good on the other side. It's not good when you want to move urea, so being sit completely, you can't move it from the plasma into the dialysis state. But when you depend on glucose for ultrafiltration to create an osmotic gradient on the dialysate side, you want that glucose to stay on the dialysate side and not go into the blood. You want it reflected completely. And that may not be possible with the peritoneal dialysis membrane, but it is there sufficiently to allow ultrafiltration. And we will talk about that. It's a rate of concentration of declining glucose and time. And so I detail for that for you in numbers. So let's go to some basic graphs. This is a typical graph of diffusion and build-up of urea in the dialysis. DP is an ocean. Dialysate to plasma concentration. Theoretically, when you put a PD, a patient on PD, and you put a fresh dialysate in their abdomen, that has zero urea from the company. And time zero, urea is going to diffuse very quickly, so by the time you get to measure, it's already not zero. But let's assume for argument's sake that it's starting at zero and it's going up. What is going up? The concentration of urea in the dialysate. The ratio to the plasma is rising very quickly. This is probably almost 1 hour here by 50%, and by 4 hours, we have almost complete equilibration of urea with the plasma. So urea is small solute, there is no barrier for its movement. This is wonderful setup to remove urea. However, once you get that 4 hours, we should not be very happy that it is flattening out. What does that mean? There's no more dialysis happening. Mass transfer have maxed. All the urea you can remove in that 2-liter dialysate has occurred, so there's no more dialysis happening or urea removal or mass transfer of urea occurring after 4 hours. Important to keep in mind when we come to prescription. This is true for urea, may not be true for other solutes. Let's see that. Here we go. So if we now put some vertical and horizontal graphs, 50% at almost 1 hour, as I mentioned to you for urea, and this is the curve is going up and it's flattening. The creatinine, a larger molecule, it's rising up slowly, or at least slower, and equilibrating less quickly at 4 hours. So here for this example, for moving, this is 70%. You give it more time, you get more. Now at 9 hours, 12 hours. So there is some dialysis that continues after the 4 hour well is extended for creatinine. Go to B12, which is taken to represent microglobulin, but the 2 microglobulin, or at least some uremic solutes that are bigger, it's almost with some imagination a flat line. What does that mean? With time, more will come out, it will not saturate, and the longer you keep that well, the more you will get of it. And the corollary of that too is that if you split it well into 2 or 3, you get this part, then you get another part, then you get another part, so as if it's equal to the straight line. So these are typical of large molecular weights going up. So it's important to remember here that if you get all the urea you want in 4 hours, and some of the creatinine you want to remove in those 4 hours, you did not remove all the B12. If you cut into a dry day here, these 2 molecules are out, sufficiently maybe, but B12 is not, and this is why the concept of dry day needs to be connected in our mind in the prescription to the residual renal function, because continued removal of middle molecules is important, and time is a factor that plays a big role here. So, let's make it a bit more complicated. This is by transport type using the Gordowski PET classification. What does that mean? Low transporter means it doesn't move urea very quickly or creatinine very quickly, so the concentration doesn't go up very fast. High transporter, it moves very, very quickly and it saturates very quickly. Most patients are between low average and high average, probably about 70-75%, and the rest are on the other sides of this median. Here we go. So DP urea, same curve I showed before, we have it at 4 hours, irrespective of the transport status. it goes up the same, very little difference. So you don't need to know the transport time when you look for urea. You can say 4 hours, I get 2 liters in the abdomen. You can even calculate very quickly the clearance of urea because it is 2 liters, it's fully equilibrated, and you make the math to make it per minute or per hour or per day. We go to creatinine, that's a bit different now. First, we mentioned that the equilibration is not full at 4 hours. Let's take it by transport status. If it is high transport, it's 80%. If it's low transport, it's 30%. Big difference compared to urea. So these patients are not dialyzing, quote unquote, as well as those patients in blue. You give them more time, they get more. But this may not be as bad as we think, and this was proven a long time ago, almost more than 20 years ago, that it is not about this small solute. It's a bit more complicated than that. But this is the concept. So let's extend that timeline for creatinine. So for high transporter, it will equilibrate, let's say at 6 hours, but then there's no more dialysis, right? Because it's saturated. For a low transporter, then it goes up slowly and start to continue to rise, really may not plateau for a while. So that's important when we think about solute removal and the length of the dwell. Let's flip the coin or the picture. Let's look at glucose. So now we switch from the plasma side, urea, creatinine, trying to move the solutes out, and we're going to go to the glucose side, which is, as I mentioned, the basis for commercially available PD solutions. And we use glucose high concentration, as you know, to pull fluid. There's no hydrostatic pressure here at play, like hemodialysis. You cannot dial in transmembrane pressure. You just need to depend on something to pull the fluid, that's glucose. So I failed to mention that. So here we go. This is exactly the flip of the verse of the creatinine or urea curves. Here, glucose is being lost from the dialysate to dialysate concentration over dialysate at 0 time. So this is the max glucose, this is the glucose at a certain hour, and if it is a fast transporter, like moving BUN or creatinine very quickly, here it is in blue again, but it is declining very quickly. Almost 60% of the glucose has been reabsorbed by 2 hours. This is not great because you're losing your power for ultrafiltration and you're gaining calories. While a low transporter will have only 20% of that glucose absorbed. Big difference. So here is the interplay between solute clearance versus glucose dissipation or loss of the gradient, and the one matters most is the glucose gradient dissipating because that's what we need. You need fluid removal. Okay, so this is going back now to the original Brodowski curves, looking at classifying patients based on what we call a PET test, the peritoneal equilibration test. It uses creatinine, it uses glucose. They measured it at 0, at 2 hours, at 4 hours. It's pretty standardized. There's a protocol, it's widely available. And then you get the numbers and you plug in your patient. You would hope that if the patient is in the blue zone here for creatinine, he or she will be in the blue zone for glucose. For the majority of patients, it matches, but you can see it's completely flipped. Red here is high transporter, red here is high transporter for glucose, dissipating fast, equilibrating fast. Okay, let's switch gears now to talk about ultrafiltration. So, for ultrafiltration, water will move from the plasma into the capillaries, as I mentioned before, to the peritoneal cavity, but also it may diffuse back. And you can look at the arrows carefully, it can go between the cells, through the cells, but there's some loss under the diaphragm from the lymphatic vessels. That is, you have negative. This is where some of the fluid you ultrafiltrate gets reabsorbed, and that's the concept. So, let's see here, this is what I showed you. I go a little bit quicker for time's sake. Here, water moving between cells and across through the cells and between the cells. The glucose mostly move 90% of it between the cells. So glucose moving back into plasma, being lost from the dialysate. Water should be moving by osmotic pull into the dialysate. This is very fine, 50-50 for the water movement between the two pathways. How do we know that? It's complicated to go over this right now, but basically from very nice studies done again 20 years ago, if you look at sodium concentration in the dialysis and within an hour, even within 1 minute, you start seeing the sodium dipping. It dips quite a bit, let's say 132. All these curves are just different ways of measuring sodium. So if it is, let's say, like commercially, it is 132, 134. It dips to almost 124. What happened here? You get more water very quickly out compared to the sodium, and you diluted the dialysis with the fresh water that's coming in from the plasma, and then sodium will follow and start equilibrating. This is sodium sipping. And we know here that if you have aquaporin non-mouths, that will not happen, and they will not dip, because there's no aquaporin. It is through the aquaporin that we see the sipping and the sodium dip. So when it is in patients, we know the ultrafiltration, let's say, is 500 cc's. Half of it is through the free water transfer, which is aquaporin. Half of it is through the ultrafiltration via small pores between the cells. So what I mentioned is correct. So let's go to some numbers and we will be close to conclude. The hydrostatic pressure in the capillary is about, let's say, 17 millimeters of mercury. The dialysate pressure is about 8 millimeters of mercury. It could be a little bit higher with high volume. So there is a little bit of a pressure gradient favoring ultrafiltration, at least hydrostatically, into the peritoneal space. This may cause some fluid to form normally. The forward power of the albumin is 26 in the capillaries when we translate oncotic pressure to millimeter of mercury. Glucose base solutions will be 0.1 without the glucose, and so we have minus 26 here, 9 gradient, so the pressure balance is negative against water movement normally. You come and you put a big osmotic pressure. Let's say plasma is 305, glucose solution, let's say the 3.86% is 486 milliosmoles. You translate this into millimeter of mercury. You do that via Van Hoff laws, very simple. And because of the reflection coefficient being 0.03%, which means only 3% of the glucose is theoretically being reflected away from being absorbed, which means you're going to lose a lot of power via Van Hoff law. That's why you drop from 3,600 millimeters of mercury for that glucose concentration to 105. But 105 is still sufficiently higher than minus 26, and you end up with a good positive ultrafiltration pressure from that osmotic gradient. You will be losing this rather quickly as glucose is lost, and because it is distributed in a spherical way, some of it may not be touching the membrane right away, let's say, and time will play a role, but that's why glucose enemy is its time, time is its enemy, because it's being lost. However, if you don't have any absorption of glucose, then you have a maximum pressure. This is what happens at the aquaporin's mouth. The aquaporin molecule mouth will see a full power of the glucose full, and that's why you have this jet of water, you can imagine it coming out, diluting the sodium in that first hour before it starts getting equilibrated with sodium moving between the cells. Iodextrin. So this is a large molecule. These numbers are the same. Iodextrin has a big oncotic pressure of 66, and that puts the gradient in a positive territory. But in fact, it is hypoosmolar compared to urine plasma, but still the balance is in favor of water moving through this oncotic gradient from the plasma into the dialysate. But the numbers here are much smaller, so the jet power is much less, but as we know, it is much more sustained. This is the glucose curve. So we see that when you put a high concentration of dextrose, you get the water going into the dialysate, you peak at a certain number, and then you lose the glucose gradient, and you start declining until you get to what's called a negative UF with time. If you have a lower concentration, that also happens, that you ultimately get negative UF, while iodextrin bags tend to be slow to move fluid, but it is sustained. That's why iodextrin is wonderful for the long wells, while it is not that helpful for a very short well to remove fluids like in an emergency. You would use 3.86%. Learning points. I hope I shared with you that prescribing PD requires further understanding of its underlying physiologic principles, that salt solute clearances can and needs to be modified, but it is no longer considered the prime goal of adequate PD. Adequate PD, the term is all out. We will learn from Dina about the new terminology of what is a good PD, what is good PD care, what is called directed PD. But we need some clearance of solutes. You need to remove your solutes, but also you need to have enough other filtration and fluid management. And it is key tool in this, the glucose or hypertension or other or things that matters. Understanding the physiology permits us to deliver PD over time, keeping in mind the perspective of membrane preservation, a topic that Dina, Dr. Latif will talk about, because you can use all this information to the best possible to create a prescription that minimizes glucose exposure, which changes the membrane over time. And you can do that by knowing the physiological principles that the patient needs, that the patient's membrane, and putting all together to have a prescription. I hope I was able to share with you these points, and I stop now. Thank you very much for having me.
Thank you very much, my dear friend Ali Abu Alfa. How are you?
Thank you. I'm doing well, thank you.
I hope to see you. Yes, thank you for this nice presentation. I'd like to ask how to preserve the membrane for a long time to prevent the decrease in the efficiency of BD.
Thank you, Dr. Thank you. I think it's a key question. It is, anyway, the holy grail in BD that we can keep the membrane the best it can be over a long time. And in a way, a patient can come to us with the membrane already, possibly more vascular, more high transport, but let's assume we have a fresh start. I think we know from Dr. Simon David's work that early glucose exposure may change the membrane to a more vascular membrane, a more faster transport membrane, which may not be as good on the long term to achieve the goals we want. What can we do to minimize glucose exposure? As I said, make sure that we understand the physiology. We tell the patient to avoid excess salt, which is something that sometimes missed in PD because you don't want to remove all this through more PD prescription, because more salt means more water. Also, to use diuretics. We know that using ACE or R preserves the membrane and decreases the incidence of anemia, but also changes the profile in terms of transport, not being as fast. And we're hoping that new research and other interventions may keep that membrane healthier over the long term. Ivermectin will play a role here in minimizing the use of glucose, because the patients who are needing higher glucose to achieve ultrafiltration are the ones that have high transport already, and ivermectin will be an important intervention there. Thanks.
Up till now, no alternative to glucose for this process of BD.
I guess there are permutations on the answer. So yes, glucose remains essential worldwide for PD-based solutions. Ivermectin is an important alternative to use for some patients, maybe in many patients. That's a different discussion. Amino acid-based solutions have been made available, but they're not widely used. But there's also the other component or aspect of this, which is the buffer, which is the more quote-unquote biocompatible membranes, the bicarbonate-based and lactate-based PD solutions. That is the discussion by itself, but these are still glucose-based. New research, there are different solutions that are being proposed for different reasons, and we will learn more about that in time.
Have you heard about the glycerin use?
Glycerin, xylitol, corn, that are solutions, a combination with they call bimodal solutions, ivermectin with glucose, but there are two molecules. Just presented discussion on PD heart failure, and there are some studies that last year that use combination, but I have not used any of them because they are all in trials, to my knowledge.
Thank you, Prof. Ali. I think the two main points Dr. Salah was asking to reserve the membrane for a long time. The using of biocompatible fluids. like ectotoxin, physiologic, neutronil, like this. The other point, to decrease the incidence of peritonitis. These are the two major causes of alteration of peritoneal membrane. According to the alteration of the peritoneal membrane, we can adjust the prescription, as Dr. Radina will mention later.
Yeah, thank you, Dr. Shah. I think you brought up a point that I did not touch on, which is the inflammation, infection that happens with peritonitis and changes the membrane either temporarily or over time. And that's an important component to keep in mind, and obviously reflects the extensive experience taking care of PD patients that can come as a surprise when you're thinking of physiology, that gets an infection and changes all the equation acutely and on the long term. I appreciate that. Thank you.
Thank you. Any questions? So we'll move to the next speaker. Thank you, Prof. Thank you very much. Nice to see you.
Nice to see you. I'll be back.
Thank you.
A wonderful PD workshop.
Thank you.
Thank you.
Thank you, Ali.